but there's a lot of opportunity to support this consumer and meet them where they are on the journey.
And they're not finding that, certainly when you talk about fast food and casual dining. I mean, for a lot of us who have gone to fast food and said, do you have any chicken that isn't fried? It seems like there are more people saying that, and they're not into pizza anymore.
That's right. Overall, restaurant spend amongst this demographic is down, as you would imagine. It's further down in quick service and fast food than it is in casual dining. Casual dining, I think, is down about 3 to 4%. Fast food is down about 9%. And that goes to this concept of when people are eating less, they tend to value quality over quantity. They're really focused on what we call permissioned indulgence. It's not about killing indulgence. It's about being more intentional about it, which is why when you go back to grocery spend, you're also seeing an uptake in certain types of packaging. People are gravitating towards premium mini type of packaging. Resealable packaging is doing well, and they're moving away from king-size foods and value-sized items, which makes a lot of sense.
The fascinating thing to me is how the growth of GLP-1s has really created a consumer-driven health phenomenon, right? Because initially, we had the shortages some 4 or 5 years ago. People couldn't get access. A lot of their employers weren't paying for it. So they wanted it. The demand was there. And they even pushed Big Pharma, Eli Lilly, to go direct to consumer with Lilly Direct.
Yeah, I think you're exactly right. I mean, if you would have told us 10 years ago that there would be a direct-to-consumer platform just for patients, I don't think we would have believed it or been able to see it. But I think you hit exactly on the point of how this all came about with Lilly Direct. Consumer demand and access weren't matching. So it was this unique opportunity to not only innovate from like a portfolio standpoint and a drug standpoint, but to say, hey, we need to innovate across how our medicines are actually delivered and obtained by patients. And so that's how Lilly Direct came about. It's a digital health platform that really tried to focus on patient centricity. What are the barriers that currently exist? Just like you said, there had been shortages in the past. We know that 50% of patients with obesity actually don't have a primary healthcare provider that they see on a consistent basis. So Lilly Direct allowed patients to have this simple and transparent way of going to get good supportive care and also a prescription medicine if the healthcare provider decided that that was the right treatment choice.
And is that growing? I would imagine a lot of people still try to get it through their insurance. But is this direct market growing more faster than PBM coverage?
It's a significant portion of, when we look at Zepbound, so one of our GLP-1 agents, we see that 50% of all new patients flow through Lilly Direct, and about 1/3 of our total prescriptions are going through. The interesting thing with Lilly Direct, too, was it was born after a PBM made a certain decision not to cover Zepbound. And so it forced us to really innovate to say, we know patients benefit from this medicine. They need to be able to get it. So what we have found with the success of Lilly Direct has also provided us the opportunity to expand access and to broaden the access conversations. And now we're on all 3 PBMs starting again October 1st. So it's broadened commercial coverage. It's also helped us unlock employer coverage. We'll talk about, I'm sure, the Bridge program later for Medicare patients. And so it's been this ripple effect across, I think, every channel that's been pretty outstanding.
It's interesting, though, that one of those big 3 pharmacy benefit managers, PBMs, Reuters reported the other day that it decided not to cover it for its own employees for weight loss. So it's an interesting thing. Coastally, everybody wants this drug. For a lot of people, even at the new pill at $200 a month, that's still a big lift, a heavy lift for most people to get access to. But, it's affecting spending for employers as well, eating up a lot of health spend these days.
Yes, exactly. I think, Ali and Laura, you've set me up well for coming in as an economist to say that what you've described, how consumer purchasing behavior is changing and how Lilly Direct is adding a new way for people to buy the medicine, those are two layers of how GLP-1s are transforming the economy. So it starts off with the drug pipeline, and we know that's expanding and evolving, indications, molecules, formulations. And then it goes through a layer of policy. Lots of laws we're watching. How will Medicare go from demonstration to future? What will Medicaid state policy do? What's the FDA going to do about the remaining compounding? All that then goes through a layer of markets, and then out comes the end result of consumers' shopping baskets changing. But there's also, we're watching what's happening to healthcare use, and ultimately are people living longer, healthier, happier lives. And so all these are different aspects that we're sort of tracking segment by segment and studying and analyzing.
You have a lovely quote about, we always talk about a moment on the lips, forever on the hips, and you're saying this is turning that around.
Yes, when you think about that old dieting phrase, right, of a moment on the lips translated into this lifetime because we didn't have a really good way of escaping our biological destiny that this was going to haunt us. But now, and this is what I'm going to ask about whether, should we expect that people would cut back on their calorie consumption, or do, for some people, GLP-1s provide a future insurance policy? Go ahead and enjoy the pleasures of eating now, because now that moment on the lips need not be a lifetime on the hips. So could it be that we might see some of that as well? I'm just curious.
We do. There's no one average GLP-1 persona out there. People are going on this drug for different reasons. We actually see in the early cohorts of people that went on it when it was available for weight loss in year 1, you can see in the data just based on how much weight they lost over time. They were either clinically obese or significantly overweight. In the more recent cohorts of who was going on this drug, over the same period of time, they're losing less weight. So you could infer maybe they're going on it for different reasons, more aesthetic, more lifestyle reasons, as the drug becomes more mainstream. So that's one difference just that we see in the data. But you also know that some people are going on this drug and saying, my doctor's in charge of my health. They've prescribed me a medicine, and I'm going to take my medicine. But I'm not going to make a lot of other lifestyle-related changes. I'm just going to take my medicine. So instead of eating a whole bag of chips, I will eat half a bag of chips. And then there's another cohort that truly uses this drug to catalyze a holistic health journey. And that's where you're seeing a lot of changes in their spending behaviors. They're joining gyms more frequently. They're completely changing their travel. They may have previously done food and wine indulgent travel. Think Vegas, think Napa Valley. We're seeing a big shift in spend towards med spas, yoga retreats, adventure vacations that are outdoors that allow people to be more agile. So you're seeing those same cohort of people not just look at this as a weight loss journey, but there's clearly a shift in identity happening. And you see that across broad categories of apparel spend. Interestingly, jewelry as a category is up almost 40% amongst GLP-1 drug users. And that's not related to changing your clothing size. That's something that people are aspiring towards. You see a shift from mass-related retail to more premium brands in terms of spend allocation. So a big uptake in women's swimwear, women's jeans, and brands that are more aspirational, more expensive. So, it's not a one-size-fits-all user out there, but there are certain themes and certain personas that come through very clearly. And the key is, and what we're advising our clients on is, figure out which demographic kind of meets your core services and core products and help target them. The only last thing I'll say here is, we liken this drug, we call it a physiological disruption, akin to technological disruptions of our time, like the smartphone. Mm-hmm. When the smartphone first came out, no one anticipated Uber or TikTok or Netflix streaming. This is not different. You are going to see new brands, new products, new industries form around this ecosystem that this drug is already creating.
I wonder, though, because there is an issue of access, who can access it through, in a more affordable way through their pharmacy benefits, who's paying cash, whether we are seeing an even greater divide that we already see in terms of health and wellness and obesity among people who are lower class who may not have access. I know, I've spoken to folks with Medicaid insurers who some states want to, but, it adds up because there's so many people who want it and so many people who need it. Is that one of the economic things that could also play out here?
I can speak to just the current state of demographics that's coming through our data that we refreshed in May 2026, and we also did a survey of 3,100 users in support of some of the more qualitative things that the data didn't show. And I'd be curious if you see the same, but demographically, we actually see pretty flat adoption across all 3 income cohorts, 17 to 23% between low, mid, and high income. And we believe this has to do with the fact that it is becoming more affordable through things like Medicaid, couponing strategies that drug manufacturers are helping to facilitate, and just broad promotions that are out there. Demographically, from an ethnicity standpoint, we see the highest percentage of people on these drugs within the Black and Hispanic community, with Caucasian being third. Gender-wise, at parity between men and women. Generationally, Gen X has the most people on this drug, followed by baby boomers, followed by millennials, followed by Gen Z. A Gen Xer is 90% more likely to be on the drug than a Gen Zer, just for point of comparison. So, this is, we think the demographics are going to continue to expand as more efficacies become on label, as the formats continue to normalize. We saw a big spike in adoption when the oral pill came out in 2026. We know there's a lot of trials going on to continue to evolve the formats, going from a weekly injection to a monthly injection, for example, and we'll continue to see increased adoption as well. The other thing, the stigma is subsiding. So early on, there was a lot of stigma associated with this. People weren't comfortable sharing that they were on the drug. In our recent surveys, much higher percentages of people are comfortable sharing with all different types of people in their lives, peers and friends, work colleagues, certainly their physicians, family members that are not in the immediate family, but extended family members. You see an increase in just openness around this drug. All those signs, we believe, point to increased adoption over time.
And I would just add a couple of things to that. I mean, I think you're spot on. We see about 1 out of 10 patients who could be eligible for these products are actually taking them. And so I think stigma plays a huge role in this, even where access exists. You see low patient penetration. And so that is something that we're really focused on, is like, how do you really educate that obesity is a chronic illness that does warrant treatment and medical intervention? The orals have been really interesting. Lilly just launched Foundeo in April, which is our first oral agent. And what we found there is, yes, there's a lower price point from an oral standpoint, a scalability standpoint, a manufacturing standpoint. But what you also see is that the oral is giving patients permission to engage when maybe they've been on the sidelines. Maybe there's a stigma related to that. There's a price component.
Or also, there are a lot of people who don't like needles.
Yes.
Yes, and there's the piece of, where are you on your journey as a patient? Because I think we say patients with obesity, but not everyone is in the same stage, and not everyone has the same needs. And so a lot of patients who have been waiting on the sidelines may not be afraid of needles. They might be saying, I don't know if I want that type of medical intervention. But an oral agent and a daily agent, maybe that's something a little bit more, less severe almost, that I can come in and experiment with along with my healthcare provider to come in. I think when we touch on access, and again, I love the facts that you shared about the patients who are on it, our goal is to expand access across the nation and across the world. And so when you look at the self-pay option that we've enabled through Lilly Direct, that's obviously one, different price points now across the portfolio. You also have the expansion and the focus on affordability through your major payers throughout the United States. The Medicare Bridge program that launches next week, July 1st, is huge for seniors.
Yeah, I wonder about that. What are you looking at forecasting, not to put out some forecast for analysts, but what are you anticipating in terms of the take-up on that when suddenly, the Bridge program is basically a new program within Medicare that
Yes.
the administration had negotiated with Lilly and with Novo, which will allow Medicare patients to access this through their benefits for a $50 copay, which is, you know, huge for a lot of people. Do you anticipate you're going to see a big surge in Medicare?
Yes, we do. I mean, there could be 20 million eligible patients alone in Medicare. And I think a $50 price point, I mean, there is criteria for patients. If you have a BMI of 35, you don't need to have a comorbidity. A BMI of 27 to 34, you need to have another comorbidity that goes with it. But that opens up access for patients at $50 a month. And that Bridge program runs through December 31st of 2027 with the goal of really proving real-world outcomes, improved cost and savings to the system across the board to then really expand access even further for the future.
Closely, you know, one of the things, Ali was talking about how this is very much like technology, and when you look at investors, the two big themes over the last couple of years have been AI and GLP-1s, which is one of the reasons when you look at the most valuable companies in this country, Eli Lilly is the only healthcare company that's in that $1 trillion cup. All the others are big AI players. How does this, if this were to become so ubiquitous, you know, like statins that so many people take, we don't even think about them now, and that has helped people with their hearts. As we potentially get more applications, I'm very curious to see what it could do for brain health. And that market is huge.
Yes, there's this ever-expanding, seemingly, number of clinical trials coming in with data, and everyone watching also longer run effects, right? So there's going to be just a lot to watch. And I want to get back to this access and policy. So Medicare, we're going to wait to see because this is the first move in Medicare. Medicaid, so it's been policy experimenting across states. So in a study that I've done with colleagues, we went back and looked at each state's Medicaid policy documents, and there've been 17 states that added a weight loss indication. Some have been starting to take it off. So we'd go and look in provider manuals and year by year see what formulations are being covered. And what we find when we then go look at what prescriptions get filled throughout all of the Medicaid program in all of the states is that the policy was very influential in whether people were able to receive this medication. So it means that in a low-income population, at least in the years we're able to study through the end of 2025, the Medicaid states' policies had a big impact on whether people filled any prescriptions. And we also find no evidence that people were switching from cash to insurance covered in those states. So it looks like when an insurance source covers it, it's bringing in new people. And we also find that even if the states had covered, so we're going to make distinctions later on, I'm sure, about the diabetes coverage versus the weight loss coverage, but we don't find any evidence of off-label prescribing. So this is going to Medicare now to say Medicare, which earlier had already diabetes coverage, does it appear this new indication will lead to a lot of new people coming in, or was there off-label prescribing? Our studies suggest
Medicare, by law at this point, is not really allowed to do weight loss. So there are a lot of people who are getting it for other indications, whether it's cardiac or obviously diabetes, and seeing those effects. I have a lot more questions, but I'm sure that folks in the audience have questions as well. So there are folks with microphones. Give them a couple of minutes to get around. But, you know, I wonder how this is going to impact the way we look at other drugs. You know, pharmacy benefits have been such a controversial thing, and there are now some employers that are looking at giving people cash And, and maybe we'll see a policy shift where you could give people cash so they can buy it on their own and basically take out the middleman. Is this something that you think could grow? Are there other categories where people will want to buy on their own?
Absolutely. I mean, Lilly launched Employer Connect, and the whole purpose of that is when you think about Lilly Direct, it's how do you directly provide to a patient a product that a healthcare professional believed was appropriate for them. And so you think about it like one-to-one. When you think about Employer Connect, that's really the scalability piece of how do you go to employers, how do you work within their budgets, also what benefits that they want to provide.
Sort of like a center of excellence model when it comes to providers.
Yes, and you tailor the solution that they need to open access for their employees. So I think you look at the traditional way of having the 3 large PBMs. I can tell you I've never seen so many options on the table through PBMs in my 23 years at Lilly. There are a ton of them on the table to help employers open access for their patients. Then through Employer Connect, we've got like 15 independent companies helping us then really tailor for those employers. Okay, if you didn't see what was acceptable to you at the PBM, do you just want to focus on the drug cost, or do you need wraparound care with that too? How do we tailor that to you? And then there's also this employer direct piece where if you say, I don't want anybody in the middle, I just want to come to you, Lilly, or a manufacturer directly, and I want to negotiate a price or a way for my employees to get access. Yes, and I don't think you'll see every employer in America do that, but I do think those that try and see that it works and they feel like they have transparency on what budget did I set? Did I come in on that budget? What cost did I expect? Is that what my employees really got out of pocket, what they paid out of pocket? Then you think about employee retention and all the benefits, productivity, et cetera. I could see this being a big movement in the future. I do think it will transform.
All right, let's see. We have a question here in the front. 1 second.
Oh, fascinating stuff. So I'm wondering, last night we heard from Dr. Manuel that within about a year, half of the people taking GLPs stop using them. So my question is, what are the, because we didn't see that with statins, iPhones, we saw it with maybe the pet rock. What's the implication for the consumer or economic activity that we've been talking about? Sort of sounds like boom and bust. I mean, it's great that 50% of people are staying on them, but half of them are dropping it.
I can take a shot at this. So here's the thing. When we survey people about why they stop taking the drug or why they lapse, the number 1 reason is cost. The number 2 is insurance coverage. The number 3 is side effects. And the percentage of people who claim each of those things, it's pretty even in terms of the reason. We know there are hundreds of trials going on right now to work towards mitigating side effects. So ultimately, that'll likely be the case. We'll see some of these side effects subside in future formats of the drug. We know that cost and access are being worked on as well. So you just have to think about, as those issues get resolved, as those barriers to entry fall, it may increase the amount of people that stay on the drug. If they don't, then it might stay the same. The other thing I'll say is in year 1, when we started to study this and see such significant changes in consumer spending patterns, we talked to our clients about it and said, hey, listen, this is something you should really pay attention to. The majority of our clients said, well, we think the adoption curve is going to remain flat because people go on and off this drug. Well, I'm here to tell you, just based on the data, the facts, the drug increased in adoption significantly in just the last year and a half. And that's when some of those barriers to entry still remain pretty high. So we anticipate a similar trajectory. And then the other thing I'll mention is if you look at the flu shot as a proxy, we know that 47% of people take their doctor up on a flu shot in their annual physical. Well, imagine a format of this drug that ultimately ends up as a once-a-year annual injection. We're not there yet, but there's definitely conversation about that someday being the case. A doctor offers a patient an annual physical, would you like a once-a-year shot for weight management? 75% of Americans are considered to be overweight, 40% are considered to be clinically obese. There is a world in which, in 10 years' time, 50 to 75% of the US adult population could be on this drug.
Well, and you will have a generic version of some of them, at least, you know, the basic semaglutide. That is coming within the next, 5 years. So that is going to open up access, I would think.
I would add one thing too. Access, we definitely see improved adherence if a patient has formulary coverage. We also see that through Lilly Direct. So it really is about the care that you provide to the patient. The one thing I think that's different in some of the comparisons too is not everybody views obesity as a chronic illness. And so you have then some healthcare providers and some patients then essentially saying, I've hit my goal weight, I'm stopping, I'm done. When you would never stop your asthma medication, you would not stop your blood pressure medication, et cetera. So there's an access component. There's also this stigma piece that is always in the background with obesity care, that patients should be able to do this with diet and exercise. An interesting fact with our oral agents, when we think about when you think about new entrants into the marketplace, what we're finding with the oral agents, is specifically with Foundeo, is that product is activating patients who are in the early stages of obesity. And we've got about 60% of our new patients really in stage 1 and 2, which is essentially meaning that they're coming in, they're taking interest, right? There are new patients coming, but they're going to need to stay on therapy. But those patients typically would get sent home. It takes them 11 rounds of diet and exercise for their healthcare professional to say, I think we need to do something differently. 11 rounds of diet and exercise. Think about if that's one annual visit and you get prescribed diet and exercise. You could be a patient with early obesity and it would take you 11 years for your doctor to say, I think we should intervene. And so we've got to speed that up. We've got to help healthcare professionals recognize, okay, it's not just about starting patients on medicine. What is the long-term strategy to help them so that they keep that off? While we're also working really hard to make sure that then they have the access and the background to help them do that in an affordable way.
I wonder about the stigma, though, for people who might be reticent. And, when you see someone who's obese and clearly has metabolic syndrome, they are struggling with their own body, you just sort of think, gosh, I wish this person could have it. But, I wonder whether they're feeling that stigma of people looking at them saying, why aren't you on a GLP-1? Could there be some backlash to that as well? Nobody wants their doctor to say, hey, you're fat, come on.
I mean, that's one of the major things that we hear from patients and healthcare providers when we say, why is it taking 11 rounds of diet and exercise for you to do something? And they say, I don't want to acknowledge that for my patient. I don't want to hurt their feelings, right? And so there is this bridge that needs to happen where there's a very empathetic way of saying, hey, this isn't about your appearance. This is about your long-term health. And so that's why we're intervening. On a hand.
Gentleman over there, and then gentleman over here.
I was curious about the current economic situation with inflation on the rise and what type of impact that might have on GLP-1 growth in terms of, people's budgets and so forth.
So I think all these forecasts we make really depend on what price point will we see new formulations coming with compared to older formulations becoming generic. So what we've seen, each new innovation is actually, even though if we say new medications come in with higher price, the price per weight loss outcome, compare the price to, especially price after rebate. So in our research, we found looking at the rebates make a big difference, of course, in what's actually being charged. New formulations have come in with a lower real price in the sense that the price per weight loss outcome is now lower. So I think it's waiting for us to see what is the whole approach that's taken by medicine, by consumers, and thinking about this now. GLP-1s introduces a new tool into our kit for self-care, for directed care? And is it going to be how much of it is a substitute versus a complement? How do we mix it with other approaches? How do we outreach? But ultimately, this is going to be, a substantial share of spending because of what people demand and see as the huge benefits.
Well, for employers and for payers, we have seen that inflationary impact because of this big surge in GLP-1 adoption. I mean, we have this, we had this Uvalde moment 12 years ago when all of a sudden you had an expensive drug that is widely used as opposed to something that's very specialized. People seem to still feel that, and that's why employers are grappling with access.
This just adds to the questions employers are grappling with also in these more small population cases of amazing new medications. What if it costs $1 million for a person? And that gets into these trade-offs of, will Medicaid cover this drug or spend on more population health? And these are unresolved questions. There's just going to be things that we're going to have to grapple with because our technology, our ability to deal with medical cases we earlier thought there was no solution for is just going to keep increasing.
I do think with employers, though, last year about 20% of employers with 200 or more employees covered GLP-1s. In 2026, so far, we're looking and estimating at about 67% of them are covering because they're recognizing
For weight loss or for
weight
diabetes?
loss, because they're recognizing that this is an investment in their workforce. When you look at like the cost of productivity loss, 9 to 23% growth across the board. When you think about short-term disability, long-term disability, workman's comp, loss of working hours, yes, there is a budget and there is a benefit design that every employer has. That's real. That's not going away. But I think the options provide them different solutions on how do you want to manage that, but they're also recognizing the overall cost that they're experiencing by not dealing with this too. So it's how do you weigh both at the same time?
But can I pick this up just quickly from a consumer spending side of things in terms of the patterns we're seeing? So based on the inflationary environment, the cost of energy, the cost of gas increasing, we are seeing probably a more value-conscious / budget-conscious consumer across all income cohorts than we've ever seen before. However, that doesn't mean that everyone's being frugal or cheap. It actually, across every income cohort, we see people are willing to splurge or spend on things that they believe are valuable to them, particularly in categories that relate to self-improvement. So we see a lot of trading off of consumer behavior, even in high income. We're seeing a lot of trading around substitutable, commoditized type items, and they're reallocating that spend towards premium travel, as an example. My view is that we will see that same behavior related to this drug over time. We're seeing an incredibly resilient consumer, 8 months in a row of retail spending growth.
Interesting. Young woman over here.
Hi, I'm wondering if we have any data yet on how purchasing decisions in healthcare have changed. Are people, when they see the results of this, more likely to address another underlying health concern?
Yeah, so I think I can speak to that. So I and my colleagues have one study, and there are 2 other studies that are also independently done, where we go and look at millions of people's healthcare records and see what happens after they start taking GLP-1. So this has been done across private health insurance records, Veterans Administration records, and then just a general study, these 3 studies. We end up finding the same thing, which is that after people start taking GLP-1s, it's not the case that they then have fewer healthcare visits or fewer spends on other things because, and this is part of understanding that this is a medication that leads to more monitoring and more visits, perhaps actually spend on other healthcare goes up a little bit. It's not surprising in the light of other medical technologies. Whenever medical technologies have come across, we're tempted to think, oh, that should mean that people then don't go to use healthcare. It has often meant in history as well that there's more healthcare use. But it's the things that we've been talking about that are outside healthcare, where we're looking for the cost savings, we're looking for employee productivity increases, or just generally, what are people able to do in their lives that they value more, for a more comprehensive look at where are we getting the payoffs.
All right, lady over here.
Going back to the data that you guys have been looking at on consumer spend, where you're seeing household adoption of this drug, are you yet noting how much percentage or dollar drop in food spend, grocery bills?
Yes, $18 per month decrease, which is roughly 5.5% decrease in grocery spend.
Okay, and are you predicting that there will be a change, or are you yet seeing a change in consumer, what's being produced, what's going into a grocery store?
Yeah, very much so. So we're working with a lot of the food and beverage companies on that exact thing. So what you're going to start to see, if you haven't already, is an increase in certain ingredients that are important attributes to people on these drugs, and that's what's being advised by their doctors. So protein, everybody's seeing protein show up everywhere. It's not, GLP-1s aren't the only reason why, but it is a catalyst for the big protein movement we see. Fiber, hydration, and then you see micronutrients like zinc, copper, and iron that help the drug be more effective in your body. So those will start to show up as well. You'll see these in restaurant menus highlighted as well. And then another important statistic is 80% of people on this drug are also taking some type of vitamin or dietary supplement alongside the drug. The most people take a protein supplement, a fiber supplement, stool softener, and magnesium. Those are the top four. We're actually seeing a 1% increase in drugstore channel spend that we believe is correlated to this increase in vitamin and dietary supplement use catalyzed by GLP-1 users.
Very interesting. Gentleman with the plaid shirt in the back. That's very interesting, given that drugstores have been falling and losing out to online for so long.
There's been a broad-based, long-standing concern about asymmetrical pricing by big pharma in the United States versus other developed countries. I'm curious to what extent the pricing levels in the United States for GLP-1s are reflecting that same asymmetry that we've seen across the broader pharmaceutical spectrum.
So the Medicare bridge negotiation actually brought the cost of medicine down too. I mean, I think there's been a lot of focus on across the world. We agree that the US shouldn't handle all of the cost of innovation. And so the Medicare unlock reflects that pricing. Cash pay price for patients reflects that pricing. I think we're missing, though, a middle piece there. That you've talked about the middlemen. If you really want to solve this, we've got to solve the healthcare system too. I think you've talked about rebates and cost, et cetera, on what really is the price, how many rebates are paid, what is the true cost of the system. So
It's interesting because that was my question to Medicare Director Chris Klomp in the Oval the day they announced that deal. And I said, well, how is this going to impact the rest of the market? So government gets this pricing, people paying cash get this pricing, but what has happened and what will happen is oftentimes what we see, for example, with providers, hospitals. They basically upcharge those of us who are paying in the private market in order to make up for the lower cost or the lower reimbursement that they're getting from government programs. Have the discussions been different this year? And is there more cooperation to get better pricing in the commercial employer market?
I think as you see access expand, there's obviously price flexibility in those discussions that unlocks broader access. And so I think as you look across self-pay, I think as you look at the expansion from a PBM standpoint, new commercial plans covering, you look at Medicare, you look at Medicaid, you look at employer, I think there are plenty of options across the board to make sure that our innovation gets to patients across the access channels.
But did the prices go down this year?
I think if you look across the board with the expansion of access, you have seen a reflection of those discussions in that.
And I just want to bring in one thing into the pricing again to think about it's not just one drug. When we think about the drug as being a bundle of characteristics that include side effects, that include efficacy, that include ease of use, right? So it's very difficult to think of, just like when we think of pricing of computers, it's not the same computer. We're seeing price increase for the top model, but the top model is always something a lot more. So that makes it hard, in addition to rebates, to really know what's happening in transparency in pricing in healthcare. We know that for all sorts of things in healthcare, and no different for drugs, I'd say.
And here in front, the young lady. From my vantage point, you are a young lady, so.
Looking for the microphone. Thank you. Thank you so much to you all. My name is Dr. Mani Keita, and I lead population health research at Deloitte. We began this conversation focusing on the consumer, and I really appreciate that. We need to anchor on communities whenever possible. And in addition to this value-seeking trait that you talked about, you also have been focusing on the empowered consumer. If you think about the threads across your notes, we're really seeing a strong sense of consumer empowerment. And I'm curious about how we can apply the conditions of the GLP-1 situation that led to consumer empowerment to other settings and needs within healthcare. That's something we've been striving for in care management and doctor-patient communication. How do we get consumers and patients to be empowered? And yet they are empowered when it comes to GLP-1s. So what is it about this scenario that we can apply to other settings for consumer empowerment?
So I think,
Perfect question to end on.
So I think you're spot on there. I think the important piece of patient centricity is understanding the barriers that those patients face in that specific therapeutic area. So what a patient with obesity struggles with is not the same of what a patient with Alzheimer's struggles with. And so if you look at the Lilly Direct example, there's also an arm of that that focuses on neuroscience and Alzheimer's. But the gap there is more about availability of diagnostics. And there's such a backlog across the nation on specialists who actually diagnose and treat patients in a timely fashion. And if you look at the new agents that have recently been brought to patients for Alzheimer's, the key piece with that is time. Because you have to intervene when the patient is in a certain stage for those medicines to work. And if you miss that window, those medicines should not be prescribed, they shouldn't be infused. And I worked in neuroscience before I took responsibility for cardiometabolic health. And the sad thing is it takes patients 17 months from the time that they say, I think I have memory and thinking issues, I notice something differently, until they wind up in the right office with the right diagnostic test. So the vision for Lilly Direct for those patients is, how do you unlock diagnostics at scale? When you think of blood-based biomarkers, et cetera, how do you make that accessible across the nation so that there aren't these 6 to 9 month wait lists to get into the exact neurologist who's in a city, right, not with your rural communities, et cetera. So I think you've really got to understand, we call it the patient journey. Where are all the leakage points? What are the barriers that they face? Our job is to put solutions in those spots to help the healthcare system really respond to those patients. And so I think you'll start to see that expand across other therapeutic areas, but we have to keep the patient at the center of everything that we're doing to understand that.
I think we've really unlocked, as you're saying, this new channels we are seeing for the first time being used in a substantial way, seeing TikTok, word of mouth, 800 numbers. How is what is being learned through this being observed by other stakeholders, employers, managed care, in saying, oh, how can we use patient engagement more through GLP-1s as a lesson for types of healthcare that we rather go and say to the healthcare provider, what do you have for me, rather than the medication being the reason I came into the doctor's office.
I'll just say it. I think the circumstances around this issue created a cultural movement that ended up being consumer-led. We have never had a solution to this weight overweight problem in America that addressed that issue at scale until this drug became available. And I think consumers rallied around that, and they're building ecosystems around that, which is a tremendous opportunity for businesses, right? It's not about panicking around what consumers now want less of or don't want anymore. It's about following what they value and helping them and supporting them on this journey of transformation. For so many people, this is an identity transformation, and as they go through it, they're reporting feeling happier and more self-confident. And just imagine what that means for our society. When you have this many adults all of a sudden feeling happier and more self-confident. There's a lot of, not necessarily all positive implications to that, but there are certainly material implications to that from a societal standpoint. And it's something to stay close to. It's an evolving space. And to really think about, how do we support these people on their journey?
I also think about if you're a parent and you are obese and now you've gotten on thinking about your health span and getting healthier, and if you have young children, maybe you will help them develop a more sustainable way of eating and a more sustainable way of dealing with their health so that we don't have these constant new generations and you don't see young children suffering from obesity at the rates that we have seen over the last, quarter century and how that's evolved. Mm-hmm. At any rate, we could go on with this forever, but we have run out of time. Thank you so much, ladies, for this wonderful conversation.
Thank you.
Wonderful questions from all of you.
Thank you.